Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm very excited today to be talking to Dr. Ira Byock, a family physician who is a longtime palliative care activist. He's the founder of the Institute for Human Caring. He's a physician, author, and advocate for seriously ill people. Dr. Byock, Ira, thank you very much for sharing what you're about to share.
It's just such a pleasure to be with you, Larry. Thank you for having me back.
Good to see you again. So I'm going to turn things over to you, and I'm really going to take notes here. Reclaiming the primacy of primary care. Why don't you go ahead and give us some background and provide your perspective?
Well, so thank you. So as you know, I began my career believing that I was going to be a rural family doc. And I went through medical school with that commitment and really believed that that was my path. I did a residency in Fresno, California. My residency diploma says UCSF, but I spent 4 years in Fresno and learned kind of cradle to grave family medicine, thinking I was going to be in a very small town. So, you know, the whole gamut of prenatal care, obstetrics, even some operative obstetrics, neonatology, emergency medicine, fracture management, a fair amount of minor surgeries, critical care, including, and then to geriatrics and end of life care. All of that. Enjoyed it all, frankly. Went out and practiced for a very short time, but because of family pressures and because the practice that I joined in a little town of Livingston, Montana, was experiencing incredible competition at the time and an economic downturn in Livingston with the moving of the railroad shops, which employed a large number of people in town. When they closed, everything was kind of involuting for a period in Livingston. And I ended up being drawn back to emergency medicine, which I had also done during my residency. And then for a year after my residency, while I was standing up a hospice program in Fresno, California. All of that's history. I've done other things now in my career, including helping to stand up hospice and palliative care as a formal specialty in the United States. But in all honesty, I've never lost that kind of purview or a worldview of a family doc, of that kind of cradle to grave care. And along the way, I've been very much involved in healthcare transformation. I spent a decade at Dartmouth on the faculty there and was actually elected to the Board of Governors of the Dartmouth-Hitchcock Health System, while my role there was in fleshing out the palliative care program at Dartmouth-Hitchcock Medical Center and the Dartmouth Health System. I was involved in the larger quest to transform that health system from volume to value, right? Since coming to the Providence Health System on the West Coast, a very large, we span over 7 states, have 53 hospitals, 120,000 employees. We are very much involved in transforming healthcare, moving from volume to value. And the healthcare system that I've been part of, Dartmouth is one, now the Providence Health System, really believes its mission, vision, and values. In all honesty, we're committed to giving the best care we possibly can, with all the challenges and with all our imperfections. We're part of American healthcare and the rough and tumble of American healthcare, but we're earnestly trying. What I want to talk about today, and what you, Larry, and I have talked about informally in the past, is both the opportunity and some of the perils that I see facing primary care in the new healthcare environment. So that's where all of this starts. Anyone who's a student of healthcare transformation will recognize the Quadruple Aim. This started with Don Berwick and the Institute for Healthcare Improvement creating the Triple Aim, better care, better quality and patient satisfaction, that's better care, improving the health, not just of individual patients, but of populations that we serve, and then reducing per capita healthcare costs, because at what, 18 to 20% of the gross domestic product, healthcare costs are really eroding other social responsibilities and commitments that we have. And frankly, we're not getting our return on that 18 to 20% GDP investment. Our health outcomes are not nearly what they could be, and less than many of the European, Scandinavian countries. We're spending far, far less in per capita healthcare. Okay, the triple aim was felt to be incomplete, and Lucian Leap and others added a fourth aim, which is improving the satisfaction and experience of healthcare clinicians, of providers. And so this is important. And that quadruple aim is something that we take seriously within the Providence Health System, but really every large health system. And I've been part of conversations with the leaderships of many healthcare systems. This has all been kind of a compass point for healthcare transformation. There are many opportunities here, but I want to also point out some of the perils. So this is a graphic that we use within Providence, looking at the past, the present, and the future. The past is a very hospital-centric healthcare system where everything kind of feeds into the hospitals, and you notice that physicians here are kind of gatekeepers, but they are a primary contact point among reasonably few contact points for patients to come into our system. We're moving through something that is putting the patients at the center, thankfully, finally, and a transitional period where there's still a lot of inputs into the health system and to our relationships with patients, but it's becoming even more. And then this one, the Health 2.0, which we envision, is a even more kind of decentralized model of healthcare with many access points, places where people can get a healthcare encounter. And that is, I think, this describes a future where healthcare in America is going. And I, frankly, am part of trying to drive to that future. So we're trying to make the best use out of that. But there are built-in, challenges to this future. I think it's, in one sense, it's inevitable. I get my own flu shot at the grocery store, sometimes at CVS. Right? I've done telehealth visits with a nurse practitioner to get medications for a sinusitis that I had. We're doing surveys through MyChart, the public-facing portal of our electronic health record. Notice that we've gone from a geographically anchored model that had hospitals, but also doctors' offices geographically anchoring the local health system, to a model that is hardly geographical. In fact, many of us are accessing healthcare, and our patients are accessing healthcare at quite a distance, including, telehealth and mental health through apps and all kinds of things, many of which are very good, but the primacy of the doctor-patient relationship is clearly being challenged. Okay, let me go back and center the experience of health and illness within our conceptual frameworks. I believe that since the advent of the problem-oriented health record, frankly, we have been teaching, usually tacitly more than explicitly, that the nature of illness, particularly serious illness, but also health in general, is medical. That we doctors are own the domain, in a sense, of health and illness, and people come to doctors with problems that we try to correct to bring them back to health. This sets us on, I believe, a misperceived frame in approaching the patients and families we wish to serve. Because fundamentally, the nature of health and illness is not medical, it's personal, intensely so. Particularly in the work that I've done in hospital-based medicine and in emergency medicine, in palliative medicine and hospice care, the nature of illness, I can tell you, is intensely personal. And in fact, as family physicians know well, whenever one individual receives a serious diagnosis, his or her family share in the illness experience. It's inevitable because we are social animals. We matter to one another. This is part of the context I want to set. So we talk about healthcare transformation. What do we mean? Well, I love to tell the story of Shirley and Harry, two people, a couple, been married for many, many years. Harry has Parkinson's disease. He has kind of Parkinson's plus. He shuffles and he's having a little cognitive deficit, and he's pretty frail. Shirley has diabetes, macular degeneration, osteoporosis, spinal stenosis, and high blood pressure. We don't meet Harry or Shirley usually until one of them falls, breaks a hip, or Shirley perhaps mistakes her medications for her blood pressure and her diabetes and ends up having a stroke or DKA or something. And once that urgency occurs, they get superb care from the ambulance to the emergency department and in the hospital. But I would submit, and again, family docs, I know this is the main audience today, understand this, that we could have served Harry and Shirley so much better had we recognized them simply as a frail elderly couple living independently. Though both of them are frail, they fit together well because they've grown together over more than 50 years of marriage. There was an opportunity to improve the quality of their care, quite possibly the quality of their life, by sending a home health nurse in or doing a home visit, making sure that we know all of their medications, making sure that they understand their medications, making sure that they can pay for their medications, but also doing things like safety checks in the home, making sure there's a ramp and we get the damn throw rugs off the floor, and there's grab bars in the bathrooms and all of that stuff that I hope is really familiar to all of us today. Healthcare transformation is possible. What I mean by healthcare transformation, and what we are trying to promote through the Providence Health System and the Institute for Human Caring, is moving from seeing patients with problems to whole persons, from individuals to persons within families and living environments, living situations, from being problem-based and problem-bound to addressing people's health and well-being, moving merely from medical treatments to what we call the fullness of human caring, and I'll explain what that means. Dr. Larry Weed, back in the mid-1970s at the University of Vermont, developed the problem-oriented medical record. And before then, I mean, it was a brilliant advance in medicine. Before then, you couldn't really understand what the last clinician was thinking often. And notes and charts were scribbled, handwritten, of course, and were almost incomprehensible, not just because of the penmanship, but because there wasn't much process. And even if there was clear thinking on the part of clinician, the notes didn't reflect that clear thinking. So Larry Weed developed the POMR, and it starts with the problem list, the table of contents for each patient. With every problem on the list, think of Shirley with diabetes and hypertension and macular degeneration and spinal stenosis and osteoporosis, you would do what? You would SOAP your notes: subjective information, objective information, an assessment, and a plan. All well and good, still a powerful way to approach patients. But I would submit that it got overlearned or more too rigidly adopted, because these days this is the box within which we teach new medical students and residents and fellows to think. People come to us with either illness or injury, and our goals of care are to fix them, right? To cure them if possible, to improve their length of life, to improve their function, particularly their physical independence, and to alleviate symptoms and suffering. And in palliative care, this is really a problem, because we've painted ourselves into that, well, we're the ones who relieve symptoms and suffering when somebody is seriously ill box. This is the corner that we're in. So, you know, when I talk to people about needing to think outside the box, this is the box that I've kind of taught young clinicians to think within, that we now have to expand. I believe that the brighter future of healthcare involves taking the lessons from, frankly, family medicine and stretching that box to include attention to the personal and family's well-being through the normal human life cycle, including the experiences of illness and caregiving and the major life transitions, which include dying and grieving. It's been helpful for me to develop this hierarchy of human caring, and you'll notice that I've with great respect and appreciation to Abraham Maslow, taken and adopted his hierarchy of human needs. And it starts at the bottom with, you know, the essentials, keeping people clean and dry, you know, protecting them from the elements, and making sure that they can eat and drink and eliminate, hygiene and all of that. On that, we layered the diagnosing and treating of their conditions and all that we do within healthcare. But beyond that, we need to make sure that what we do in healthcare is aligned with what they actually want, that every treatment is preceded by a pause to make sure that the person's values, preferences, and priorities are reflected in the clinical treatment or care plan, right? That different people with the very same condition and comorbidities may make different choices. Why? Because illness is personal. It's only partly medical. So the disease treatment algorithms that I have and believe in need to be applied, but they need to be adapted and applied in a highly personalized way. Otherwise, it's not quality. Beyond that, when somebody is seriously ill, it involves not just alleviating their suffering, but helping them with the what I've written about for years as the developmental tasks of life completion and life closure, the tasks in a developmental realm, because Maslow, Erikson, Piaget all focused on early childhood or adolescent development, but all of them recognized and said explicitly at some point in their writings that human development is a lifelong process. And we as family docs know that they were right, that it does continue. Not for everybody, you know, sometimes people don't achieve those life, that's the landmarks of late life completion, but it's available to many more people than we might imagine. And then I'll talk about fostering well-being, particularly honoring and celebrating really is a recognition that the human condition is a connected one, and that we have an opportunity to help people within their families and communities to have a sense of completion, that we can, in a sense, wake people from life. We can honor and celebrate the fullness of our lives and relationships, even as people are leaving this life. I'll get to the point now. So I ask myself, so this is what I want to do for the rest of this little talk. I want to talk about reclaiming the primacy of primary care. And some I believe, transformational technologies that can help us practice in a way that is good for patients, as well as providing that quadruple aim of satisfaction, job satisfaction or professional satisfaction, and even bringing back joy in the practice of medicine. What are doctors for? I've been asking this question and writing and talking about it for a lot of years. Well, what doctors are for first is indeed saving lives, fixing those illnesses and injuries. We're for prevention of injuries and diseases and disabilities whenever possible. We want to extend life when cure is not possible, helping people to live as fully as possible with chronic conditions that in the pre-scientific era would have killed them: diabetes, infections, chronic conditions like Harry and Shirley have had. Alleviating symptoms and improving people's comfort, and whenever possible, optimizing their function and functional independence. That gets us pretty far down the road. Doctors, I believe, are also for improving quality of individual and family well-being beyond the problem-based, beyond that problem-based box, to improve, our quality of life, to help people to thrive and even flourish within the context of families and communities. We're here to assist people with decision-making in an ever more complex medical healthcare environment, when decisions are not simple, when there are alternatives that are legitimate to people's complex conditions with heart failure or cancer or both, and so many other conditions that provide treatment alternatives, each of which have potential benefits, but also known burdens and risks that have to be balanced. We can accompany people through some of the more difficult times of illness and disability and caregiving. And as I said, support people to thrive in families and communities. This is an article by Oliver Sacks, published posthumously in the New Yorker, and in which he talks about growing up in a family of physicians. Even before my own medical education, I learned an essential truth about doctoring from my parents, both physicians, that being a physician involves more than handing out diagnoses and treatment. It involves playing a role in some of the most intimate decisions of a patient's life. This requires considerable amount of human delicacy and judgment, no less than medical judgment and knowledge. Isn't that get to the kind of the crux of what so many of us feel is real doctoring, and that satisfying aspect of the doctor-patient therapeutic relationship, the intimate relationship, the trusting relationship? That's what fills me up as a clinician, that intimacy. So here's what was jarring. I just picked this out. I could have shown other aspects of things that I think illuminate the problem, but this one I come back to again and again as a study that sort of woke me up. And I have to say, when I first read this study, in the process of it, I went through 10 minutes of thinking, wow, this is great. What a great intervention and study. And then I had this change. So this is a study published not very long ago out of Stanford and the VA there, in which they trained up a bunch of lay health workers to have goals of care conversations with veterans in the Palo Alto VA system, and looked at the outcomes of kind of goal concordance and whether that impacted healthcare use and intensivity of care in the months following the clinical trial. Okay, so these lay health workers were trained and then had conversations with patients, and they randomized the trial to an intervention group and a group with usual care. And as you can see, the outcomes are terrific. Goals of care documented in the patient's health records improved dramatically from 17.5% to over 92%. Satisfaction with the providers of care improved. There was no change in death, but in 30 days before death, there was more hospice use quite significantly. Emergency department visits dropped, hospitalizations dropped, and the costs were dramatically different between the intervention group with just over $1,000 and the control group of well over $23,000. Awesome. And then they conclude, incorporating a lay health worker into cancer care increases goals of care documentation and patient satisfaction and reduces healthcare use and costs at the end of life. Fabulous. But what are doctors for? I mean, having those goals of care conversations, that shared decision-making, accompanying people through these most difficult times in their lives seems to be at the center of the bullseye of what you and I as physicians are for. What are doctors for? This really troubles me. Are we to outsource goals of care conversations with seriously ill patients? Do we not have time to do that? And if so, like, what are we for? It seems to me that outsourcing a goals of care conversation in the doctor-patient relationship is a little bit like outsourcing sex in a marriage. I mean, isn't that one of the key reasons we came together as a couple, right? Something is misplaced here. What are doctors for? I worry about this. Now, I have a family doctor. I've actually had, because I've moved, I've had 2 family physicians in the last handful of years, in the last, let's say, 7 years. Both happen to be women, and I like them both very much. But as much as I love and identify with family practice, I would not want either of their jobs. Their jobs these days are pretty perfunctory. They go through my usual health screening and vaccinations, and they manage my medications and refills. But honestly, I'm not sure either of them would recognize me if we walked past one another on a street. We do not have a particularly close, intimate relationship. The most happy family doctors, actually primary care doctors that I know these days, are concierge medicine doctors. And that may appall some of you, but that's my experience. Concierge medical doctors have the time to talk with patients. They have the time and have smaller panels so that they can come to know their patients as a person. They often share their contact information with patients because that trusting relationship is such that it's not abused. And it's highly satisfying to the doctors in these doctor-patient relationships because they're less drained by the demands of patient care as they are filled up by the satisfactions of patient care. So I said early on that I was going to look at several things about reclaiming primary care and some of the technology that I think actually feeds into a transformation in healthcare that reclaims this primacy. One of those things is the personalized health record. Now, I've scanned a lot of health records and talked to clinicians and IT people at many health systems. I haven't really found the perfect electronic health record that I envision in my mind's eye. This is a screenshot from Patient Wisdom, a vendor of patient interfaces that syncs up with some health records, including the Epic health record. So I'm using this, and this belongs to Patient Wisdom, which is a company. But notice what this would look like. Imagine a future in which when you opened a patient's chart, you saw a thumbnail of the patient's picture, which helps you remember who this person is. And I have to say, for me, This is really powerful because I often cannot remember the names of people, but if I see their face, I know them immediately. I remember the stories, I remember their background. It triggers for me memories that sometimes I can't quite associate with names. As I envision it, this thumbnail would have behind it iterative previous thumbnails looking back over time, so that if I wanted to, I could click on it and look at how this person has changed year to year over time. It has what's most important to the person, how, in this case, she would describe herself, what her main health issue is here, how she's feeling about things, what makes her happy, her health priorities, barriers. You get it, right? This is really helpful, and I think can help us as busy clinicians provide a genuinely personalized interface and relationship with people. That's number one. I'll spend more time on the second technical innovation that I believe is coming, but needs family medicine's input to make best use of. And that is something called patient-reported outcomes, which is really better described as patient-reported information, because a lot of the information isn't actually outcomes. It's just inputs provided by the patient. And this is something that I believe will be coming in the future as a routine exercise for people to engage in at home or in the waiting room or in various other ways through computer adaptive learning, so that the things that we ask people feel, and indeed genuinely are, tailored to who they are as a whole person. So PRI, routinizing patient-reported information, is a methodology for identifying both medical and non-medical problems that are actionable. It provides a simple way of screening and monitoring for physical health, for functional capacity, independence, ADLs, activities of daily living, and IADLs, the instrumental activities of daily living, as well as their emotional, social, spiritual distress or well-being, and the important social determinants of health, where they live, who they live with, what the social impacts to their function and quality of life are. It provides data relevant to their personal priorities. It doesn't obviate having shared decision-making conversations or goals of care conversations, but it can help tee this up. And it accelerates transition in healthcare transformation from that problem-based model to a highly personalized model of care. It helps us move from individual health to population health. Remember the Triple Aim, a better patient experience and quality. That's number one. Number two is better health for populations, not only individual patients. So I'll take you through these. These are slides that I've created with imperfect graphic skills, but we'll take you through how I understand and I'm trying to build, by the way, within our Providence Health System, a PRI capacity that will be routinized using digital tools to personalize, authentically personalize healthcare and patient experience. So imagine if somebody is home working on their tablet prior to an appointment, maybe it's the annual wellness visit or other appointed visits, and we start with key things that we hope we're always asking patients in the privacy of their home or in the privacy of the waiting room with a secure tablet in their hand. We ask, do you feel safe at home? That's pretty key. Notice on the right, I have the basic human needs and personal well-being, functional and social determinants. Do you feel safe in your neighborhood? Do you have enough to eat? Nutritional safety. Do you have money for basic needs, right? How often does pain make it hard to do the things you want to do? How often are you bothered by little interest or pleasure in doing things? Some of you will notice that some of these items that I've mocked up for this illustration come from things like the PHQ-9 and other frequently used screening tools. With attribution. I'm just using this as an illustration. How often are you bothered by feeling down or depressed or hopeless? Are you at peace? This is Dr. Karen Steinhauser's well-validated single item screening tool for spiritual well-being or distress. Do you have any sexual problems or questions? This is something that I think in primary care is rarely asked. I've never been asked it by the two family doctors who I like very much during the last 7 or more years of being a patient of primary care. And yet it's important. And if we don't ask it, we'll not know about it. Do you have problems washing yourself? ADLs. Getting dressed. Using the toilet or bowel movements. Do you worry about wetting yourself? There's a famous study that when elderly folks, and I say elderly, those are people that of an age that I now am, when they were asked about their main concerns in their life, incontinence and transportation were the two ones that came to the top of the list. Who knew? And yet it makes sense, doesn't it? Are you able to shop for yourself? Manage your finances? Are you able to buy your medications? Do you sometimes have to skip doses of medicines? Are you caring for a family member or friend? Are you lonely? We know that loneliness is the new smoking. Are you able to get to stores? Are you able to visit friends? Just imagine if every visit, appointed visit, was preceded by a survey of this sort. Now, it wouldn't be the same survey every time. We have now artificial intelligence and machine learning. And so women with uteruses wouldn't be asked about prostatic symptoms. I wouldn't be asked about menstruation or later menopausal symptoms. And this get tailored because a transsexual man might still be asked if he has had a pap smear or has been screened for breast cancer and the like, right? The computer would learn who you are and would ask questions relevant to you and your past medical history. The person with diabetes who is 75 years old would see a different survey than somebody much younger who had different conditions or no chronic conditions at all. Imagine if when you open that chart, after that first page that had the patient's thumbnail, you saw a graph of their function, their emotional well-being, and some of their chief concerns. I've just chosen these as illustrations, but just imagine if you could see that, and let's say you saw that their level of emotional well-being was straight for a while or varied a little bit from time to time, and then took a turn up, and they were having more depressive symptoms or anxiety symptoms. It would change the short visit that you had with them. It would change the priorities from perhaps, just looking at the A1C and doing a foot check that day to talking about why their emotional, their mood, and their outlook had changed significantly. This is a way of expanding the scope and the depth of the clinical encounter without significantly lengthening the clinical encounter. It's efficient, but it's also person-centered. Before I close on this and we open it up and converse, Larry, I want to just go through a little bit more about this fostering well-being. This is something that I've been working on for many years, as you know, in my work in hospice and palliative care. What is well-being through human life. Sigmund Freud was once asked to define mental health, and as the story was told, or as I heard the story, he was actually walking through a crowd at the time, and somebody yelled out, Dr. Freud, how do you define mental health? And he said, it's the ability to work and to love. Wow, not bad at all. I pondered that one for years. The ability to work and love. I mean, you don't have to be in a good mood, feeling optimistic, or happy to be mentally healthy. You can be living through difficult circumstances. You can be living through a divorce, or living through an economic depression in your country, or even through times of social upheaval. And if you can work and love, yeah, that you're pretty healthy. I mean, intact. I think well-being requires the ability, at least occasionally, to laugh, which is a marker for at least occasionally to experiencing joy. Now, I'm often asked, because of my clinical specialty these days and the focus of caring for people at the far edge of life and illness and frailty of age and decline, how about when work is no longer relevant to a person's stage in life, when they are too frail because of age or illness? From my perspective, and I have no data really on this, I've got a tiny bit, but not enough to assert, that well-being in decline involves the ability to love, to feel loved, and again, at least occasionally, to experience joy. I learned this not from a medical text or research as much as from my dad. This is my father in 1981, Seymour Byock, holding and locking eyes with my eldest daughter, Leela. I don't know if it comes through on your screen, but Dad and Leela are ecstatic. Now, my dad was living with pancreatic cancer. This picture was taken just a few months before he died. My dad hated being ill. He hated the fact that he was dying. He loved life. He was a lusty man in many regards. But my dad was joyful this day. My dad never lost his capacity to laugh, at least occasionally, and to feel joy. I imagine my father to be well within himself during the period of time that we would consider him to be dying. His story, by the way, opens my first book, Dying Well. It's a book of stories about the capacity for well-being at the far edge of life. It's stories about people who taught me some aspect of human development through the end of life. And I felt I needed to begin with my dad's story. Well-being is possible. Healthcare transformation is possible. We can provide better care, better patient experience, do it not only for patients, but their families and the larger community we serve. Do it at lower cost. The most expensive treatments we provide to patients in American healthcare are things it turns out they wouldn't have wanted had we actually paused to have a conversation with them. I believe that primary care is essential to the bright future of healthcare transformation, and that it is essential that we reclaim the primacy of primary care if we are going to fulfill the potential, the bright potential for healthcare transformation. So with that, I'll close and turn it back to you, Larry, and I'm happy to continue to converse.
Thank you so much for that. What really struck me is the family physician's perspective. And I've been doing a lot of reading, a lot of thinking, a lot of writing actually about the history of family medicine and what family medicine, I call it the revolution. Family medicine's a movement. It came in the 60s and 70s, and it has transformed academic medical centers. It's transformed the practice of medicine. And your philosophy aligns so well with the vision of the founders. And you're transforming end-of-life care especially, and to hear you share your perspective and what's at the center of that perspective, which is to love and to work and to laugh, at least occasionally. I mean, that is so antithetical to the traditional, what would you call it, the doctrine of medicine, of
Oh,
physician as scientist.
let
It's
me
just
let me
wonderful to hear.
thank you. Let me recraft that just slightly. I think that the the next big thing, not only in healthcare culture, but in American culture writ large, ought to be the genuine human potential for well-being, even as we are leaving this life. As a doctor, my fondest hope for the patients that I know and have the privilege of serving is to promote their well-being through the entirety of human life. I know from my work, my clinical experience, and a bit of the research that I've done, that many people retain the capacity for well-being even in the waning stages of life. That's something that's not out there. It's not acknowledged nearly enough. And again, I think that family doctors are at this tip of the spear of this transformation.
I think you're absolutely right. There's a couple comments that I'd like to make. You
Yeah.
mentioned the concierge medicine, the happiness of the concierge medicine. I suspect you know about direct primary care.
Yes.
So when I've told people, we've either sponsored or co-sponsored the Direct Primary Care National Summit every year since 2013. And I tell people that we have never had a presentation in all of those years on physician burnout. If you want to see what hundreds of happy doctors look like, you come to our Direct Primary Care Summit meeting, because that's what they all are. There's no burnout's gone once they're free from the constrictures that are imposed by a third party paying for things. So I absolutely agree with what you're saying. The other thing I'll mention is time. So the rate limiting step for what you're talking about in the transformation to what I would call a primary care driven system is the time that doctors and their team members are allowed to invest in their patients. And that is the focal point where we have to stay. Things need to change. You have to give the family physicians, the general internists, the general pediatricians time to do their magic. And then the magic happens and we get the kind of outcomes that are much better. The final comment I'll make is, are you familiar with How's Your Health?
It is familiar. I'm trying to now locate it in my brain.
So
Remind me.
John
Oh yeah.
Wasson,
Oh
an
yes, of
internist.
course. Oh, of course. From Dartmouth. Yes.
Yeah. So I'm going to send you some information, a link to that, because I think um, what you're looking for is already been developed by John and his colleagues in the Dartmouth Co-op.
So yes, let me say about time, that you're absolutely right. And the reason that time is so short is because primary care is misunderstood and misused within the larger healthcare systems that we belong to or have to deal with. What I mean by that is that we are seen either as gatekeepers to expensive care or as producers, and we need to bank a certain number of RVUs and charges, to prove our worth. In the value-based environment, as we move from that health 1.0 to health 2.0, from volume to value, we need to reinvent or redesign primary care so that there is time to know each patient as a person, but also so that there's time in our schedule. So if one of our patients ends up in a hospital with a complex medical problem, we're the one doing the goals of care conversation. We're the one who is helping to guide that person through a complex set of choices, and a potential acute care or post-acute care journey. Anything that we do to align what the plan of care is with what people's personal priorities are in service of actually achievable physical and functional goals will ultimately be efficient. Maybe not for each person, but over a population or a patient panel, clearly would save enormous amounts of money compared to what's happening today. Anything that we do that can diminish the area under the curve of hospital use for our patient panel, not avoiding hospitals entirely, but using them for what they can do, and then getting people out of the hospital as soon as possible so that care continues in a subacute or home environment, is efficient and drives value, better quality at lower costs. But that's going to require having time in the day to either physically go to a hospital occasionally when one of our patients is there, or to Zoom into the hospital to do video visits and family meetings. I believe that's within the purview of the primary care doctor, certainly the family doctor. Who else should be doing that better, right? And so instead of just complaining about the hospital medicine doctors or the critical care doctors who don't know and they don't care, and that's not quite true. They're really good, caring people. They're overwhelmingly busy, and they are doing transactional medicine. They are fixing problems, right? We're the ones with that therapeutic relationship who ought to show up, lean forward, and be engaged in that intimacy of the therapeutic relationship, helping people through this difficult time in their life and their family's life.
I couldn't agree with you more. I think that what people who are listening to this right now are hearing is the future of family medicine.
I hope so.
And it's the future of a primary care driven system that delivers better value for all involved. And it's going to cost less to do this when things are done right up front. So I want to thank you very much for your presentation. I'm excited to share this, and just thank you so much for the work that you're doing, Ira.
Likewise, Larry. Thank you for allowing me to share my thoughts with you today.